Hi there, my name is Holly Tanner with the Herman and Wallace Pelvic Rehab Institute, and I'm here with Steve Dischiavi to tell us about his athletic pelvic health course. Steve, can you start by telling us a little bit about yourself and your background?
Sure. It's good to see you. Thanks for having me. I've been with Herman and Wallace now, I think about 10 years, teaching this and various forms of this course in terms of the pelvic floor content with regard to kind of bridging to the sports medicine world. With me not being an internal physical therapist, it's been really kind of a unique situation having me involved with Herman and Wallace for so long. My background comes from I'm a manually trained orthopedic and sports PT, board certified through the APTA, athletic trainer, PT. Got my master's in PT, went back, got my doctoral degree in PT, and now I'm pursuing my PhD and doing some research. So that's been interesting. So that's kind of my academic background, my professional background. 10 years in outpatient ortho, running clinics for a big corporate entity type of place. Then went 10 years pro sports with NHL, which is really how I've got linked into Herman and Wallace because of all the hip pelvic disorders I was dealing with, having to deal and interact pretty closely with pelvic floor therapists. And that's where I think the blend kind of came in, and they eventually asked me to come teach. And that's been where that road has led. And now the last 7 or so years of my career have been in academia, teaching PT, still keeping my hands in clinical practice. Twice a week, I'm in the athletic training room working with the athletes. My title role here is director of rehab. So I really try to help with a lot of the surgical cases that we have. So I think that kind of captures what I do professionally.
Excellent. And can you tell us a little bit about the contents of the course? What can folks expect to learn about when they come to your class?
I'll try to capture the answer to that with a lot of what the participants will say back to me sometimes after the course, sometimes the emails I get, or even during the interactions during the course. Because I think to myself, my first thought process is if I'm an internal pelvic health practitioner, why would I want to go take a course with someone who doesn't even do that? What could they potentially help my skill set with someone who really doesn't spend time working in the same environment I'm in? And I've always respected that question. When I look at my course from a 30,000 foot view, the thing that will attract an experienced physical therapist that's doing internal pelvic health care would be the amount of consideration that goes into the design of therapeutic exercise specifically, and how some of the latest research should be impacting exercises directed at the pelvic floor. And things, just to give you kind of a brief example of what that might be, those are some of the relationships between the lower extremity and the pelvis and the lower back, and how does the lumbopelvic-hip complex influence the pelvic floor. And when we really start looking at exercise prescriptions specifically for the athletic population, the massive amount of complexity that goes into athletic movement typically is not reflected in the therapeutic exercises in the way we deliver them. So where I really try to tie those two worlds together are an update on some of the most contemporary evidence with regard to lumbopelvic hip exercise prescription, and what are the specific implications to the pelvic floor, and what should the pelvic floor therapist be thinking about when they start prescribing more global appreciation of exercises specific to that region. And the class is interesting too, because you're trying to bridge two populations. Many of the people that take the athlete course with Herman and Wallace are first time Herman and Wallace course takers, if you will. So sometimes what they'll say is they're oftentimes not internal pelvic floor. They don't have the career trajectory potentially to want to do internal work. But like myself, they know that the pelvic floor is an integral part of how athletes perform. So they're really trying to gain an increase in understanding of what ways can I influence the pelvic floor as a non-internal pelvic floor therapist. So I think when you start talking about delivering that content to either an early learner in the pelvic floor community, or potentially someone that's has a sports and ortho background but wants to learn more about the pelvic floor, there's a lot of ground to cover when you have those two types of people in one course.
Mhm.
So I think the feedback on the course would be for someone that's just starting out in that journey, they start to really get that passion for, okay, I'm a sports and ortho clinician, but there's so much about the pelvic floor that could be influencing my day to day activities just in terms of either injury rehab or potentially performance enhancement. And then you look at the other end for clinicians who've been working on the pelvic floor for years and years, they turn around and say, wow, I've really never looked at the pelvic floor through the lens that you deliver it in terms of this global appreciation for kinematic movement from the entire lower extremity kinematic chain up through the lumbopelvic-hip region, and how simple concepts like length tension relationships can alter how the pelvic floor functions. And I think that's some of the feedback that you hear from those two groups.
Absolutely. And in reading the course evaluations, no one seems to mind that this is a remote course. In other words, everyone is so thrilled with all of the video examples and the practical things that they're doing wherever they are to go ahead and impart these skills.
Yeah, it's interesting because I think when COVID hit and we talked about maybe making some remote courses and trying to keep the content online, I was, just to be transparent, initially skeptical to think I've never really taken the content and tried to transfer it to an online environment. So, which is really true with some of the things that we've even seen here at the university through the academic learning for our graduate students. Some of the things that we thought might not transfer really well have actually opened new doors for us. So I think online learning has been adapted throughout multiple disciplines, through our disciplines and academics and corporate environments, but it's transferred, like you said, actually really nicely. And I think I was initially surprised. And then when I felt like I got maybe a two or three courses under my belt and really started to work out some of the things that I thought weren't transferring really well, now I think we've got it at the point where I think the respondents have, like you said, been very positive. And emails that I'll get after the course, people will say, I was kind of reluctant to take this type of course remotely. And then they go on to say all the things that they thought why it went well for them. So I think a couple of the easy things are, I've tried really hard to make, like you said, the videos very descriptive. So the content gets delivered in a very specific way. I show the demonstration through video of whatever exercise or technique we're working on. Then I myself show a live demo on remotely. And then the third option that's been really nice is if the participant chooses to use their video for me to observe, I can look at a whole screen full of tiles of people exercising, and I start to give the group feedback as a whole real time,
Mhm.
just reminding them, okay, I can see some of you are doing this, some of you are doing that. And then I can see everybody kind of making the needed adaptations and modifications as I'm speaking. So they can use that in multiple different ways. They can use it as a generalized feedback mechanism. And then some of them will actually say, can you watch me individually just to make sure I have it right? And then we can give individual feedback. So, and I'm pretty easygoing, I think, when it comes to the course because I've given the registrants the ability to contact me afterwards. So if they have questions once they get back in the clinic, they can reach back out and say, we were doing this and I'm not sure if we were doing it right. So we can have a quick conversation about it. And that too has been an added benefit of this remote style is I can hop on a quick meeting with someone or a small group at a clinic and have a quick follow-up conversation. And I think that's been some added value for the participants that have taken some of the courses has been this feeling, okay, it's not this one and done kind of thing. I think I would speak for probably most of the Herman and Wallace faculty. I think that's part of being the community. I think that's part of being part of something that you have that ability. Hey, once you've come and taken one of our courses,
Mhm.
I've always say jokingly during the class, once you've taken a class with me, we're friends. Here's my email, keep in touch. Those are the things. If you're an instructor with Herman and Wallace, those are probably the things that's the wind in your sails. That's the thing you like doing is making those connections and helping people problem solve and sharing unique conversations. So I think that's also been one of the positive things that's come out of the remote kind of learning style.
That's fantastic. One of the things you might remember me emailing you about is some of the feedback I've had from other colleagues, very experienced colleagues, and their takeaway from your course is that some of the specific exercises geared towards the hip and pelvic floor really have helped them get their patients who have chronic pain and specifically obturator and turnus dysfunction and really lift them out of that chronic pain pattern. And I remember emailing you saying, "What is this about? This is so fantastic." Can you share a little bit about that philosophy perhaps? And I know it was really the tall kneeling and the half kneeling diagonal pattern type movements that were just showing up in the clinic as being so remarkable as really shifting that chronic pain experience for someone. Can you share a little bit about that philosophy there?
Sure. I think there is a unique kind of transference with the exercise application that we do see specifically to the pelvic floor. And to not go into, again, talking about wind in the sails, if you get me going down this road, I will tend to want to talk more and more about it just because I'm passionate about it. But
Mhm.
the kind of the uniqueness in the structural and the anatomy adaptations of the pelvic floor when we talk about how the lumbopelvic-hip operates, one of the unique patterns that we see is when the exercises are delivered in a more rotational manner, when the joint is loaded, it seems to have a very interesting effect on the pelvic floor itself, which is what we see in the hip as sports and ortho practitioners. So some of these same benefits that you get in your quote unquote, I hate to just pigeonhole patients as pelvic floor patients or hip patients or low
Sure.
back patients, but I think that's how you get this bridge conversation between, wow, we see this just in remote joints, peripheral joints as sports and ortho clinicians, specifically the hip and shoulder. And then we start talking about why we're seeing this integration, the same patterning with regard to the pelvic floor. And then we put it under the same neurologic context that we see it happen at other parts of the body. And then we start to, I really think that speaks to the sports and ortho clinicians because I think they're sometimes mystified by the pelvic floor and they don't understand much about it. So it seems like it's this entity that you don't understand, you don't really learn about it in your educational background. You have to go on for additional training.
Mhm.
And I think that's sometimes a nice hook for the or sports and ortho clinicians because they're like, oh yeah, I already know this principle. I already see it happen at other joints. It would make sense that it would happen in the pelvic floor. And then I think for the pelvic floor therapists, it's nice for them sometimes to back away from the pelvic floor, remove themselves one or two lenses and say, when I look at this a little more globally and I appreciate the movement as a whole, now I can see and relate to the impact that we might be having with real specific application strategies. So you're right, it does seem to be that transition period between, we always talk about the athlete class. Usually the last thing you're doing with somebody is something single leg because they're running, jumping, planting, cutting, and something as stable as laying on your back. There's these kind of transitional positions, which are half and tall kneeling, that offer great opportunities to get the best of both worlds, where you can still be in a relatively stable pattern, but still be loaded in the pelvis and the hip joint. It allows a nice transition of exercises between lower level stability exercises and higher level athletic looking exercises. And a lot of times by the end of the course, people will say that seems to be that transition that they really like. Now they see a way to get their patients off the table, but not doing such high level exercises that are aggravating to the patient. These tall kneel, half kneel combinations are really nice place to see some of these neurologic changes between the lumbopelvic hip region and then carry over into more athletic maneuvers.
And I've noticed the buy-in from the patients is tremendous because they see the differences side to side oftentimes, or just they notice how difficult it is to balance in those positions. So I think that the deficits show up for them so clearly in those patterns that they think, wow, I better work on this, you know? So that's
It's
really
really
exciting.
interesting you say that. Yeah, it's real interesting you say that too, because we see that with the course participants, as they're most course participants are dealing with something themselves. And we as therapists, as being active individuals, will usually have our own hip issues or low back pain, or and then we talk about as the course is going on, we talk about these breadcrumbs that you're trying to kind of lay through the course for yourself because you're doing things on your right side and your left side. And
Mhm.
then the course participants themselves will say, I'm a PT. I should be able to figure out these problems on myself, but I usually never spend enough self-care time
Mhm.
to actually deal with some of these things. But by the end of a 2-day course, they've put a lot of pieces together on their own self. which I think you mentioned kind of therapeutic alliance where the patient really gets the quick buy-in. It's really interesting to see the course participant get to the end of the class and for them to be excited about, oh, I've always had this problem, but I've already seen such quick results with some of these things on myself.
Yeah.
They may actually be taking more time on themselves and some more self-care application for them as clinicians and patients. So it's interesting to see both the therapeutic alliance that you get from the patient and the actual buy-in from the participants after they've gone through a 2-day course where they can start seeing some of those imbalance deficits on themselves.
Right. And the enthusiasm on the participants' part is just has been really clear. So I know anyone who signs up for your course is going to be thrilled with the outcomes. And again, thanks for taking some time to share information about yourself and about the class.
No, I appreciate you having me on, and you're right. It's a fun class. You don't sit. You're usually up and moving and engaged the whole time. So I have liked that in terms of it being a remote class. We've been able to keep that energy and engagement up.
Fantastic. Well, thanks again, Steve.
Thank you.